Okay, all right. Thank you very much. So, um, I'll proceed. Okay, I'll start from the start. Hindi pala ako narinig kanina. So again, maraming salamat po sa National Voluntary Blood Services Program na for this invitation to talk about the IPC measures in mobile blood donation activities. It's a very timely and very important topic actually to talk about, since we know that we have to continue with um, meeting the demand, providing the supply of blood for the needs of the country. But of course, we have to balance this out as to how we could protect our donors and staff with this mobile blood donation activities. Okay, so we all know that we have that the basic understanding is that safe blood is an essential life-saving resource. Blood transfusions, they're very much needed for a wide range of health conditions. So may mga predictable demands and unpredictable health conditions such as anemia, complications of during pregnancy and childbirth, severe trauma due to accidents, surgical procedures. Those are examples of and unpredictable demands of blood. But they're also being regularly used for patients with conditions such as sickle cell disease, thalassemia, and for products that treat hemophilia. So essentially, it's very crucial and essential resources to save lives. And we want to ensure that this demand is met. So there's a challenge to maintain sufficiently stable and safe blood supply, especially that we have the blood is low or has limited shelf life. And in addition to that, there are also other external factors that play in the maintenance of the supply of blood, which also actually includes this unpredictable pandemic. So uh, no one was able to say naman na mangyayari to, and this pandemic is going to happen, and that it poses a challenge in terms of getting voluntary blood donation. Okay, so um, we have this administrative order, the 2020-0007. It's recently been signed, entitled National Policy on Patient Safety in Health Facilities. And in that policy, the blood safety is a key priority area for patient safety. So we want to ensure that we maintain safe and effective procedures around the collection, storage, and also the use of donated blood. And a few relevant strategies are listed. So we want to encourage health facilities, blood centers to prioritize, not just blood centers, even other health facilities that utilize um, blood and blood products, to really use strategies to ensure that we are providing safe blood for those who need them. So some relevant strategies. Now we want to implement guidelines in the health facility on safe blood and blood products. Of course, establish 100% blood collection from regular, voluntary, non-remunerated blood donors from low-risk population, and also create policy for post-transfusion incident management. In the context of COVID pandemic, of course, there are added challenges with this. Given our current situation, we the meeting of the demand, ensuring that we have an adequate supply, is really very difficult. Of course, number one, the donation of blood products is essential for community health, and it relies solely on the donation from healthy donors. And along with this, the need also for transfusion and medication based on blood components continue despite the COVID-19 pandemic. So the demand remains to be high. Okay? However, some scheduled donations, scheduled donation appointments, and even blood drives are canceled due to lockdown. So we've been in lockdown for the longest time, and we're told to stay at home. So for these actually interrupt the supply of blood. And moreover, there's reduced public activities. So with the reduced public activity, it triggers reluctance, okay, to provide venues for mobile blood drives. And of course, people are not willing to go out. So there's that fear, no? So I think the most palpable and most pressing issue that we need to always manage would be yung fear or the lack of confidence of people, of our healthy donors, potential donors, their lack of confidence in blood donation. So there's that fear, well, I get COVID-19 at the blood center or from the environment or while traveling to a blood center. Okay? So nonetheless, okay, mobile blood donation activities, so despite all those challenges, we know that mobile blood donation activities are actually essential to maintain adequate supply of safe blood. So for as long as conditions permit, this actually serves better, okay? As donors need to travel less. So we go to the potential donors, get to screen them there, and then obtain blood products. So somehow we manage to bridge the logistical needs, logistical gaps. Of course, the priority is always to protect the health and safety of donors, of patients, and staff in the conduct of your mobile blood donation activity. So when we talk about provision of safe blood, so to ensure that we actually provide safe blood, we have to make sure that the staff, okay, our volunteers are protected, the donors are safe, and of course, we provide a clean environment and equipment. So there's always that interplay of three factors, so that we provide a safe supply of blood and blood components. So now we have to be extra careful, especially considering there's COVID around, pandemic is still here. So the importance of IPC measures, infection prevention and control measures, could not be overemphasized. So in the interim guidelines, so there, WHO has released their interim guidelines last March 2020 on maintaining a safe and adequate blood supply during the pandemic outbreak of COVID-19. And in that document, they provide several strategies, or actually they encourage employing several strategies to mitigate the risks. So they have 7 different points. So first is the potential risk of transmission through the transmission of blood and blood components, so to mitigate the risk of that. And of course, mitigate the risk of staff and donor exposure to COVID-19 virus. Mitigate the risk of the impact of reduced availability of blood donors. Manage the demand for the blood and the blood products. To ensure the undisrupted supplies of critical material and equipment for in the conduct of blood drives. Communication to stakeholders to ensure that we have continuous confidence in obtaining or in the conduct of blood drives and encouraging the donation and the collection of convalescent plasma. So for the purpose of this talk, this discussion, so I will just touch and talk about the first 2 points. Okay, so in maintaining the safety of the blood, actually, there are several considerations, no? And we know that respiratory viruses, so in the context of COVID-19, they have never been reported to be transmitted through blood or blood components. Therefore, if we do measures to mitigate the potential risk of transmission by transfusion, they're actually theoretical, and our measures are therefore precautionary. So theoretical pa lang yung risk of transmission. So, potential donors, could be educated, but they need to, of course, self-defer based on the risk factors of COVID-19 or feeling unwell. So there are several strategies, several measures that we could use: pre-donation, post-donation. Okay, so pre-donation, we educate our donors, about what are the signs and symptoms. If you're feeling unwell, then you have to self-defer. Okay, and of course, with education, with capacity building, we also have to supplement that with thorough screening. So aside from the usual blood donor screening questions, we also ask COVID-19 screening questions, travel history, contact history, signs and symptoms of the past days, past 14 days. So these information are not just important to triage donors who could potentially be effective, but also it's for the post-donation activity, because we want to of course monitor, kung meron pong mga donor natin, successful donor na asymptomatic pala previously and then being symptomatic. Okay, so and then what do we do with their blood products, etc. So even post-donation activity, we could do that reminder for symptom reporting within 28 days of donation. And in case, of course, of transfusion to immunocompromised patients, or let's say if evidence would indicate that there's risk in the future of transmission through the blood, and an additional margin of safety can be employed through the pathogen reduction. So pathogen reduction measures has published evidence that it could reduce viral load in plasma and platelet products. So there's this article if you wish to look into it. But of course, it requires significant logistical and financial investment. So in ensuring safe staff and donor, we know that any transmission from a donor in a blood facility or mobile blood drive, that any transmission is far more likely to occur through the respiratory route, okay, for COVID-19, than through parenteral routes, even including phlebotomy during blood donation. So it is possible, actually, that an infected donor who is asymptomatic or pre-symptomatic and with mild symptoms may infect other donors and staff, definitely. And so we want to be thorough with the infection prevention and control measures, okay, for the protection of the people, our volunteers and donors, and the conduct of mobile blood drives. Okay, so infection prevention and control principle is actually it's a combination of scientific approach and practical solution to prevent harm caused by infection to patients and health workers, patients, health worker, and our okay, and it basically involves multidisciplines, okay, such as our infectious disease. We also have epidemiology there, our social science, and health system strengthening, and the use of IPC, our infection prevention and control measures for mobile blood drive activities during COVID pandemic is a combination of our public health measures and employing hazard prevention in the workplace. So when we talk about hazard prevention, okay, so this is a peer inverted pyramid. It's a diagram of the hierarchy of control. So we want to implement controls in order to prevent hazard. So our identified hazard here is the COVID-19 infection. So this diagram, okay, is an inverted pyramid. So we see that the least effective, okay, the least effective method is PPE, The use of PPE, yes, it has value, but in terms of, in comparison with other possible controls, it's actually the least effective. But when we talk about PPE, so it is to protect the worker using personal protective equipment, our masks, our gloves, okay, our gowns, isolation gowns. And excuse me, we also have other controls that we could use, our administrative controls, which refer to, we want to change the way people work in the workplace, and then our engineering controls. So here we employ several um, pwede kasi siyang infra or processes, so they're incorporated, the design is incorporated into the way we do things at work so that we could isolate people from the hazard. So in the context of COVID-19 pandemic, you want to emphasize the employment, the use of admin and engineering controls. So these two, okay, to mitigate the risk of infection. And kasi nga, like I said, no, the use of PPE is not enough. Although yes, it could provide protection, but we need more than just that. Okay. So in ensuring that our donor, okay, the person, we're talking about our potential donor here, is safe. No? Of course, we want to only accept eligible and healthy individuals. So we only allow those identified healthy, eligible individuals to be named. And like I mentioned earlier, aside from the donor history questionnaire, so we also employ COVID-19 screening. So pwede tayong gumamit ng screening forms. I think we always encounter that even if in other establishments, no, just we go to restaurants for a takeout. So once you enter an establishment, so they provide this form to assess for exposure, travel history, etc. So we want to do extensive donor screening strategies. And DOH has this policy, the department memorandum entitled Interim Guidelines on Ensuring Blood Safety and Adequacy for COVID-19 Response. And they actually have, that policy has good outline of different criteria, when to defer potential donor, how do we refer if we have exposure, possible exposure, and even your blood collection protocol. So strategies, of course, you have to screen for signs and symptoms even prior to entering the donation center or donation area. So we have to have thorough screening. Anything that would be a red flag of a potential infection, then we defer them. Okay, we cannot overemphasize the value of hand hygiene, considering that coronavirus can be transmitted through droplets. So hand hygiene, the proper hand washing can go a long way in protecting the individual and stopping the spread of the disease. So of course, if the hand hygiene facility, so there's no easy access or enough access to water and soap, then alcohol-based drops, okay, which can be provided to donors, would suffice. And then for protection, yeah, everyone is required to wear face mask at all times. So it's also very prudent if our donors to enter donation center, we ask them to wear face mask, proper wearing of face mask at all times. Maintaining physical distancing, so we keep on hearing this, and this actually has a value, a huge value. Physical distancing at least 3 feet or 1 meter to reduce the possible spread of viral particles. So of course, we wouldn't want some coughing potential donor to enter the donation center, the donation area. So physical distancing is an added measure first layer pa rin natin always is we screen for signs and symptoms and not allowing those with signs and symptoms to enter. And then last but definitely not the least is education and capacity building. Okay, so this could go a long way in terms of working hand in hand with the donor, possibly after donation, nagkaroon sila they develop the signs and symptoms. So we educating them what to look out for, what to expect, and what's beyond the normal. Then they could help mitigate the risk as well of spreading infection, and of course the notify, so be able to notify the center. These are the patients who were able to donate successfully, but then nag-develop sila ng symptoms. For our staff and volunteers, the routine IPC measures actually the same for the donor practices. So utilizing the proper hand washing, physical distancing as well, wearing of masks at all times, your screening of symptoms. Okay, so they're the same as our donor practices. But we also want to add a layer of healthcare worker risk assessment. Before duty, after duty, so let's just be proactive in terms of monitoring our signs and symptoms, because basically there's potential of exposure. And then frequent hand washing, as I mentioned, and the wear of appropriate personal protective equipment. So just like donors, we ask them to wear face masks at all times, and then for our staff and volunteers. And of course, during venipuncture, we wear gloves. And aside from that, we do temperature and symptom check before and after duty. So before and after we go into blood donation, mobile blood drive activity, or before and after duty sa ating blood centers. Okay, so if you remember this diagram again, so like I said, we also want to employ engineering and administrative control. So now let me talk more about administrative controls. And when we talk about administrative controls, they are strategies that would change the way people work to mitigate the risk of infection. So we want to institutionalize some important strategies and measures, IPC measures, to enhance compliance. So madali lang kasi sabihin, okay, do this, you do that, you do this, you do that. But oftentimes, since we do a lot of things all together, then there's that possibility of us to forget, and so we want to avoid that because there's a potential venue for infection. Okay, so what are some administrative control strategies? So the policies. So we have to set policies and guidelines. There's that guidance, okay, for our donor, for our staff and volunteers, that they will know what to do and what to do, when to follow, how to follow, etc., etc. Okay, so for example, so these are just examples. Okay, so when we do blood donation activity, we have guidelines that we don't allow companion. We don't allow companion. We defer our deferral and referral guidelines. So we actually have that policy already, so we can utilize that. Triaging, and then the mandatory temperature and symptom check, and then establish and communicate the workflow within the blood facility. Education. So if we do formal orientation of potential donors and staff on symptoms, so like I said, capacity building and education could go a long way. And if we orient them on the processes inside or during the conduct of mobile blood donation activity, they will know where to go, what's the next step, and so on and so forth, what to watch out for, what are the precautionary measures that would also help mitigate the risk. Protocols on monitoring and reporting of symptoms. So this is actually particularly important for our staff. Okay? If they develop the symptoms, then where do they go? Who will they talk to report? Sometimes that could be yun pala yung factor that is preventing them from reporting kasi they don't know who to talk to or where to go to. Okay? And aside from that, if you have a protocol on following up on donors, so being proactive in terms of following up your donors regarding the development of symptoms after, let's say, 14 days or 22 days. Another strategy is to employ a standard staff health assessment prior to all blood drives. Okay, so just like I mentioned earlier, no, yung health worker risk assessment that could be used. Actually, WHO has released that checklist that we could also utilize. DOH encourages the use of that health worker risk assessment, and we could use that. Okay, that standard staff health assessment prior to the blood donation activity. And then if we have actually person in charge, an IPC person in charge, identified to oversee, to make sure that all protocols and measures are being implemented properly, okay? Then that would actually help maintain ensuring that within the blood drive activity that everything goes, that we're following the standards. Okay, and then now we go into the engineering controls. So the Department of Health also has this policy, okay, on the providing guidelines on enhancing the infection prevention and control measures for engineering and environmental controls in health facilities during the COVID-19. So it's a DM 2020-0208. So when we talk about engineering controls, okay, so these are actually methods, activities, okay, that are built into the design of the place. So pwedeng they use the infra, your actual infra, yung tent ninyo, how you design your triage table, so on and so forth. So it's incorporated either in the design of the place, the equipment, or the processes to minimize the hazards. It's a very reliable way to control exposures of the worker, as long as the controls are designed, used, and maintained properly. Okay, so it's an example. So like I said earlier, no, if we provide a triage area separate from the donation area, we provide a triage area to assess potential donors. So this triage area, this assessment area should be separate from the donation area. So as much as possible, we don't want a potentially sick person to enter the donation area and then, of course, infecting many others. No? So we designed that the triage area should separate. That's where they fill their health declaration forms. Okay, and then we apply our protocol on referral. If the potential donor is at risk or symptomatic, and then that could also be a place where we do our health education for donors. So there's already a mixing of your engineering control and your administrative control. And of course, I think if you've seen it, and I think you could also hear it and see it, yung using of non-porous material, if you can see may mga plastic, clear plastic. They actually term it the sneeze guard, the quote-unquote sneeze guard. So you have that clear non-porous plastic that would separate the personnel, the staff from the patient. Actually, the picture doesn't clearly see it. Show, no, if you have a separator here, okay, that would separate your staff in the triage area. Of course, wearing appropriate PPE, and then your potential donor. So you assess if the donor is, of course, eligible and healthy for blood donation, and if that donor is not at risk or is not exposed to potential COVID-19 patient. Okay, another engineering control, okay, to ensure clean environment. So we use we employ appropriate disinfection of high touch surfaces in equipment. So what are we talking about this here? So all our workstations, countertops, the equipment that we use, uh, tables, chairs, handles, even yung hand grip balls na ginagamit ng donors, okay, doorknobs, handrails, etc. So they should be cleaned and disinfected frequently. And WHO gives us this guideline that we use 70% ethyl alcohol to disinfect small surface areas and equipment between uses, okay, such as reusable dedicated equipment. Example nito yung BP apparatus that we use to check for our potential donor, checking the vitals. So between uses, we have to disinfect them properly. And then sodium hypochlorite, specifically for disinfecting wider surfaces. And if there's blood or bodily fluid spills, we use the same at a higher concentration. And in addition to that, we also enhance the disinfection of blood transportation vehicles. So hindi lang within the mobile blood drive infra, the donation center, but also the transportation vehicle that we use to bring the blood products. So like I said, disinfection of donation, the equipment, the materials that we use in between donors or in between use, every after use rather. So that includes our donation chair, okay, disinfection of donation chair every after donation. The linen and bed sheet every after donation. Although of course this would pose this is going to be a challenge, no? Magdadala tayo ng a lot of linen and bed sheet in a blood drive activity. Well, we could encourage also donors if they could bring their own. If cannot, then that would be a logistical limitation. If you can only bring 50, then we have 50. If you can only bring 25, then it's 25. Tedious, yes, but it's a good IPC measure. We provide also foot-operated trash bins where we could store, throw away tissue, used masks, and the PPE, of course, properly labeled. And then hand washing facilities are present at strategic locations. So kung meron po tayong access to water and soap, that would be the best. Kung wala po, then alcohol-based hand rubs at strategic locations. So at the waiting area, near our donation chair, or if you could provide alcohol-based hand rubs to the donor in the kit, so that it was so be good. Other physical measures, okay, to ensure that we do the blood drive in a well-ventilated area. So, hindi po kulog. There's a good flow of air. Okay? And then maintain physical distancing practices between donor beds, in waiting, and refreshment areas. There's this manual of World Health Organization on their SARI treatment. Although, of course, mobile blood donation activities is nowhere near a SARI treatment, but they employ a 2-meter distance between donor beds because it would to allow movement of the staff in between beds. So I think that's also a good strategy to employ, no? Para hindi rin dikit-dikit. So yes, a minimum of at least 3 feet or 1 meter physical distance between donors or between donor beds, but it's going to be tight for the movement of your staff. So if you'd give it more space, then that would be more there's ease in terms of movement and also maintaining the distance from between the donor as well as your volunteer staff. And of course, in the waiting and refreshment area, so we cannot, we have to emphasize this, we cannot huddle, we cannot talk and be in big groups, or actually be in groups, okay, to also mitigate the risk. Markings. So markings could go a long way. Visual markings could help people, okay, donors, staff, to guide them where to go, what to do. Okay, this is pala the proper distance to keep. Okay? So we could use that too. Then separate restrooms for staff and donors. That would also be a good control to utilize. And then I mentioned earlier, additional barrier using clear non-porous material. So yung ano po natin, the clear plastic that we often see, that would be a good additional strategy, a good additional engineering control. Lastly, okay, ensure clear foot traffic. So when you say clear foot traffic, wala pong banggaan, and it's communicated well to the people moving around the area where to go next, what's the procedure. Okay, so firstly, okay, if you have separate entrances for staff and donor, so para lang din with the toilet, that way we would also protect actually both staff and the donor. Of course, we avoid mingling and utilization of the same material, the same infra. So then there's going to be an extra, that's going to be an extra precautionary measure. Establish a clear workflow and donor movement in the donation centers. It has to be unidirectional. So the donor has to enter at one point and then exit at another. Okay, so unidirectional. Let me show you an example. This is, I think, one good example from the Ministry of Health in Bhutan. So they've adapted the WHO guidelines that I discussed earlier, and then they created their national guidance on maintaining safe and adequate blood supply. So in the guidelines, so they show this floor plan for blood donation campaign. So you can see it's clear, no? And if this is going to be communicated to your staff, then they would know what to do, what's going to happen next. Okay? And from an intending donor entering the facility, they have to be screened with the donor questionnaire. So, syempre, dito na rin yung triaging for the COVID-19 health check. Okay, I'm sorry, screening. And then we do the donor screening, body weight, BP, and then if accepted, then we do the registration, blood collection, then refreshment, deferred, then immediately exit. This is supplemented with this, I think this is some sort of a poster that they also show to the patient, to the donor. Okay, so these questions are going to be asked from you by the triage, and then these are the steps that you could take, and then this would be the workflow, okay, so that you will know where to go. So from the triage area, okay, you do the screening. So they're utilizing parallel teams. So you have donor screening registration. Okay, then they issue the blood bag or the kit perhaps, and then to the collection area. So this is where the patient, and then your staff, and then exit to refreshment section, and then exit. So so establishing a clear workflow, okay, and it's communicating it as well to both the donor and then the staff. It would be helpful to know where they are, where to go next, and then establish that unidirectional foot traffic. Okay, so other safety measures that could be used, okay, do the post-donation reminder. So as discussed earlier, now in maintaining safe blood, we also have post-donation activities that we could use, and to set a reminder, excuse me, to the donors, such as maybe perhaps maybe giving them like a checklist, you know, what to watch out for, and then contact numbers, who to call, when to call, what's the appropriate time frame that you give them so that they could watch out for the symptoms. Okay? And then maybe do proactive cross-checking, okay, of confirmed cases or symptom development. So hindi lang na mag-aantay, not just to wait for the donors to call, but also as the center itself could call or to follow up, no, have you developed actually any symptom. Okay? And lastly, maybe encourage appointments or utilize appointment systems, so that way we avoid crowding within the um, facility or the area, the donation area when we do our blood drive, mobile blood drive. Okay, so the question is mobile blood drive, okay, possible during COVID-19 pandemic? And of course, the answer is yes. Actually, we want to do that, no? But of course, there are logistical or challenges rather that we have to face, no? For one, definitely it would require a bigger site, no? And perhaps you would expect less donation more than before, because more than the usual, because we're limiting. We must limit the crowd. So in a blood drive, we often target, or we could get about 100 donation, maybe now, which we could expect about 50% of that only. Yeah. Definitely, during COVID-19 pandemic, mobile blood drive serves the donor better. So, hindi na po sila magta-travel going to the facility, but we bring the material, the equipment to them. So I think if I'm a blood donor and I really want to donate blood, I would want that. More logistical needs, okay, to ensure adequate protection. So like I said, you have to employ some engineering controls as well. The linens and the disinfection, the use of the PPE supply also is going to be high as well. So there's going to be more logistical needs, so that to ensure the safety of the staff, the volunteer, and the donor. And of course, you have to balance the demand and supply. We all know that there's a continuous demand for that blood and blood products. And as much as possible, we want to meet that by getting adequate supply. But of course, like I said, the priority is always safety first. So we have to ensure that when we conduct that mobile blood donation activity, all measures should be in place, properly placed. Kung konti lang, we could only meet a fewer donation than usual, then that would be okay for now, given that we are in the middle of a health crisis. Okay, so I've also listed some a link to some policies and guidelines that maybe could utilize if you wish, in terms of maintaining the different IPC measures that we could use in the conduct of mobile blood drive activity. Okay, thank you for listening, and I'm welcome. Your questions are welcome.
All right, thank you very much, Dr. C. So we will encourage or we will entertain your questions through our chat room. So if you do have questions right now, wag na pong mag-atubiling mag-type. We do have a question from Mr. Carlos. So is there a maximum number of blood donors every mobile blood donation, Dr. C?
Is there a maximum number of donors? Actually, we don't. There's strictly speaking, we cannot say na ito lang yung, this is our cap. I think that would greatly depend on the capacity of the blood drive. So again, logistics. So if there's going to be a limitation there, kung if you can only cater to so number of, let's say, 20 lang, no, of people because you have limited space, and you have, let's say, this is limitation in terms of linen, or in terms of equipment, and that's it. But there's really no number set in stone that this is our mobile blood donation.
All right, thank you very much, Dr. C. Another question regarding the linens. What is the better replacement for linens po? Because every blood donor we have to replace our linens po. Thank you.
Regarding, repeat the question. Are you talking about the linens?
Are there any better replacement, Doc, for the linens? Since it was discussed a while ago that every blood donor, we must change our bed linens. So are there any better replacement for this? A more cost-efficient replacement po?
That's a good question. Although I cannot think of any, but I am not familiar with this. But I suppose the linens that are used with during blood donation activities are just the regular ones, right? It's not a special kind. For as long as it's provided a maintenance one, a bed sheet. Am I correct?
Sorry, hindi ko narinig masyado. Sorry, Doc, may you please, yes, Dr. C, kindly repeat your answer, Doc. We are having technical difficulties here, so may we suggest for you to repeat the answer po? Or the question?
Yeah, sure. Actually, I don't have an answer to that question because I suppose outside the context of the pandemic, mobile blood donation is the usual type of linen, kumot, and then bed sheet, right?
Yes, yes po, Doc.
We don't use anything special, right? I'm sorry, but I'm not very much familiar with when it comes to those. So with that thought, then I suppose any other linen that would serves its purpose, provide enough warmth, and then clean bed for the donor to lie on, then that would be a good alternative already. I think wala namang anything special. It doesn't require any special linen naman din eh. For as long as you have that, you provide, for as long as it meets the function. Encourage lang natin na to choose the linen every donor because precisely they want to prevent potential, no, source of virus. So, we never know if asymptomatic yung isang donor. So, if we use the same linen for several donors, then potential risk.
Mm-hmm. All right. Okay po, thank you very much, Dr. See, another question from Ms. Jelly Banawan. So since there are asymptomatic cases of COVID-19 nowadays, we could unknowingly collect blood from a potential COVID-19 positive blood donor. How do we effectively assess donors during this pandemic daw po?
Yes, it's actually a very good question. So we feel that no, always the asymptomatic cases kasi it's easier to defer those with symptoms. Pero pag if they present with nothing, or with the questionnaire and then the assessment of the triage, they say no to any contact history or any travel history, any signs and symptoms, and then but eventually they turn out positive pala, then that's going to be it poses a fear, no? How do we effectively assess? In terms of assessment, mobile blood donation activity, I think doing a proper screening in the triage area is the most that we could do. Of course, we cannot say naman you have to come in with test result negative. Actually, even in public health perspective, we do not push for that. So the assessment, thorough triage area, okay, partnered, implemented with adequate measures within the donation area. So, mga IPC measures na mentioned, employ your engineering controls, you have to make sure that the patient is wearing mask, sorry, not the patient, the donor is wearing mask all the time. The staff are also following protocols and measures, then the risk would reduce. Would be reduced. Of course, kailangan natin to be, shall I say, be proactive in terms of following up our donors. They develop signs and symptoms 14 days, 28 days after they've been tested. Then, if yes, then we do, of course, the quarantine of our contact tracing, and sino bang nag-handle for this patient. So then we would have a more prompt response to the situation. It's really challenging. It's really challenging to be able to identify and defer properly asymptomatic cases. But like I said, it has to be multifactorial. You're not just going to rely on assessment area. Okay, of course, you have to employ but you also have to supplement it with good IPC measures within the donation center, within the donation area, to protect others as well.
All right, but Dr. C, thank you very much. Another question, Doc, is it advisable to use plastic cover in cut beds, the one you use nowadays during MDDs, then disinfect it per donor's usage?
I'm sorry, can you repeat that? The
plastic cover in cut beds, Doc. If it is advisable for us to use plastic cover in cut beds and to disinfect this plastic cover every after donor po. Yes.
So it's like you wrap around the bed, is that right? With the plastic cover.
Yes, Doc. The plastic cover will be wrapped around to the cut beds instead of the linens, and then after every donor, we will disinfect the plastic cover po. Is it advisable?
Okay, the way I imagine it is now, if your cut bed and then you put a plastic cover around it. Is it advisable? Um, I have yet to see articles giving it as evidence, no, na symptomatic. Of course, the premise here is if that donor is already inside the donation area, okay, o about to donate na, then the screen na siya properly, di ba?
Yes
Then we
po.
would defer if they're symptomatic patients. So let's say that patient is symptomatic with face mask on, and then you will put that um, plastic. It's like maybe okay. I have no I haven't encountered articles yet on proving that this would be work. This would give additional benefit for people or patients that are symptomatic or COVID, not COVID patients. But I maybe it would actually cost as well to the donor if they're wrapped around the plastic, and then it would actually cost just reduce ventilation within the that small area. And then secondly, it also doesn't address the contact of the contact of a potential asymptomatic or pre-symptomatic to the linen, and then utilizing that linen for another donor as well.
All right. Okay po.
Yep.
Okay. Yes po, Doc. Thank you, Doc. So moving on for our next question from Dr. Asanyon. So clinicians are concerned about blood safety for their transfusing patients. Will PRT be encouraged to ensure blood safety since based on studies on SARS-CoV-1 and MERS-CoV, which are genetically similar to SARS-CoV-2, transmission through blood is possible in 1% of cases? So, Doc, is PRT being, will PRT must be encouraged to ensure blood safety po?
PRT, right? PRT, pathogen reduction therapy, is that right?
Yes po, Doctora.
Yeah. Is it being encouraged? I think I am not the right person to be able to answer this one. In terms of the guidelines of how to treat blood and blood products and possible virus, reducing viral load. Although in some countries, like I think in Hong Kong, they already utilize pathogen reduction therapy in plasma, which is a product, okay? And it was proven, it was published evidence. It is already proven, right, to be able to reduce the viral load. So in terms of if we need it, is it a must for us to do it here? I believe I'm not the right person to be able to answer that one, but it could provide, my own point of view, it could provide an additional safety measure, additional margin of safety, especially if we transfuse the blood to immunocompromised patients. Okay. And I think we all know that study of coronavirus, we're still unfolding new information about this. We still learn many new information about this as we go through this pandemic. And who knows, maybe in the future, I hope it doesn't happen, but in the future that it really proves that we could transfuse the virus significantly, then definitely we must employ the PRT.
Thank you very much, Dr. C. Ms. Jelly, follow-up question po, if a patient is transfused with blood of an asymptomatic COVID-19 blood donor, are there pros and cons for the patient? Thank you, Doc.
Are there pros and cons for the patient? Maybe I am not, I basically, in an infection prevention and control. Um, and scientifically speaking, as in if there is really that 1% chance of being able to transmit the virus, no, through blood products, then yeah, it's going to be dangerous. Definitely, there's a risk rather. There's a risk for the patient that was transfused um, with blood from an asymptomatic patient. But um, we have to weigh uh, benefits, risks, and benefits in terms of blood donation. We know for a fact that, hello, am I still being heard? Yep. Hello, I hope I'm still being heard. Okay, so we know for a fact that blood and blood products really is a life-saving resource. So I suppose this was when that blood was transfused to the patient, and then eventually we found out that it's an asymptomatic patient pala. It was for a good reason, no? Kinakailangan. It was much needed. Some WHO gives the guideline that we should like hold a sort of quote unquote quarantine some the blood until after we are assured that um, the donor is not symptomatic or is not turning out to be COVID patient. But of course, there are we have to blood service laboratories. No, we have to provide also pre-transfusion investigations. No, kasi the lifespan of the blood, I believe, is quite short, so we cannot um, hold it for prolonged or store it rather for a long time for just to wait and see. Maybe a pathologist will be able to better answer this question. It's actually a very relevant one. Public health and IPC wise perspective, um, we have to really employ these strategies and different controls and assessment to ensure that we are able to filter out properly potential donors so that we could get blood and blood products that will be safe for use. I hope that somehow clears the question. I know it's not a direct answer to the question, but I believe a pathologist will be able to answer this more in depth to give more clarity to that question. Yep. Hello.
Can you hear me? Hello po, Doc?
Yep. Yep.
Right. So that is the end of our question and answer forum for the first topic. And without further ado, we will present. Thank you very much, Dr. Resi, for sparing your time with us and sharing your ideas regarding infection and prevention control principles in the conduct of community mobile blood donations. So as a simple token of appreciation, we would like to present this certificate to you. So I will read this. Republic of the Philippines, Department of Health, Public Health Services Team National Voluntary Blood Services Program award this Certificate of Appreciation to Dr. Brilliancy in grateful appreciation for her invaluable dedication and commitment for sharing her expertise as one of the webinar speakers of National Blood Donors Month 2020 Dugo Yan Yan, Isang Pamilya, Isang Lahi, Isang Bansa on 28 July 2020, facilitated by the National Voluntary Blood Services Program of the Department of Health in celebration of the National Blood Donors Month from 28th to 30th of July 2020. So issued on 28th of July 2020 in Quezon City, Philippines, signed by our dear Assistant Secretary of Health, Mr. Nestor F. Santiago Jr., our head at Public Health Services team. So once again, together with all the NVBSP staff and the leaders, thank you very much, Dr. Brilliancy.
Sure, thank you very much.
Okay, so I hope natuto po tayong lahat. Madami po tayong mga questions. I know, nakita po namin dito sa chat room. And sana masagutan po natin yan mamaya-maya po. So, furthermore, let's move forward. Since sabi nga nila, hindi lang po isa ang topic natin ngayon, kundi dalawa. So let me introduce to you our next speaker. Our next speaker is a graduate of University of Santo Tomas, having the bachelor's degree in medical technology. And he also specialized in blood banking at University of Illinois, USA. He also do have a diploma in management and human relations at Las Vegas. And he do have this most outstanding medical technologies award during the 54th annual convention last December 3, 2018. And other than that, he is also a member of PAMIT USA. He is also not only just a member, but the USA National President of PAMIT. So for his professional summary, 37 years of practice in the blood bank industry, over 25 years of supervisory and managerial experience, transfusion service, blood component manufacturing, reference laboratory, quality assurance, record review departments. Let me introduce to you the one and only Professor Felicimo, or you can call him Ricky D. Martinez Jr.
Nakamute pa ako. Do you guys hear me? Ayan. Hello, nakamute pa ako. Do you guys hear me? We can hear you.
Yes, Professor, we can hear you.
Okay. Good morning, folks. Thank you for the invitation. Actually, I've been looking forward to this, and ang dami na nag-ano. Yes po, Professor. By the way, sabi ko kay Ma'am Joanne Oliver when they invited me, please do not introduce me as Professor. Hindi ako Professor. Ako po ay abang teacher lamang po. Anyway, my topic today is I place it now and future trends in blood banking. Oh, by the way, do you guys see me? See me? Yes? Sagot kayo. Do you see me? Oh, okay. Great, great. Okay. Anyway, I placed this, I made this topic because most of these trends are already being enforced many years ago. And they have been here decades. Baka yung iba naman na experience yan, sabihin nila. O bakit future? Hopefully, my main learning objective to this presentation is if we do not do these practices, I hope that we can adopt them and use them. All right, next slide, please. Okay, this presentation is based on the experiences following the AABB standards. Okay, this is actually my experiences. Okay, before I start, I'd like to make a short survey. Please do not flood. Okay, thank you. Please do not flood. I just have two questions, and it's very quick. Who among us, the participants in here right now, I know I have a lot because I invited a lot. Just answer yes or no. If we perform antibody screening as part of our pre-transfusion testing, if you do, just say yes. If you don't, answer no. If you are in the academe, just write academe. If you are a student, just write student. Thank you. And the second question is, if we perform cross-matching, I know we do perform cross-matching, do we either use the method tube technique or the gel technique? That's it. Next slide, please. All right. I'd like to discuss briefly on the pre-transfusion testing. We know that blood is classified as a drug. It's a medication. We cannot transfuse blood without the doctor's prescription. And there are three orders or physician's order. Number one is type and hold. The other one is type and screen. The other one is type and cross-match. Type and hold. What are the pre and cons of type and hold? When we do type and hold, we just draw the blood from the specimen. We perform ABO-RH typing forward and reverse, and we hold the specimen for 3 days. We do not do anything else except to prepare for the blood typing and hold it for the next 3 days. What is the disadvantage of this? The disadvantage of this is it may be too expensive for some facilities, because what happened in my experience is we draw a bunch of tubes at one time. What is the purpose of that? Is so we would not stick the patient many times if in case it's needed. That is the disadvantage. What is the advantage? The advantage is if we have a type and hold, we can go ahead and perform type and screen. We just perform the screening and we hold it for the next 3 days. If in case the doctor wanted a cross-match or to transfuse a patient, then we will do a cross-match. If there is a positive antibody screen, there should be antibody identification. Once we identify the antibody, if the antibody is clinically significant, we select an antigen-negative blood to avoid hemolytic transfusion reaction or delayed hemolytic transfusion reaction. If the antibody identified is classified as clinically insignificant, we would still perform a cross-match. Next slide, please. Natutulog siya. Okay. What is pre-transfusion testing? The cross-match is an important part of routine pre-transfusion testing. It is used to detect ABO incompatibility and clinically significant antibodies. Is this the mukhang mukhang lumipad tayo dito. Can we go back to the previous slides? Okay, next slide. Oh, okay. Originally, the cross-match was intended to be the final check for ABO compatibility and for the detection of unexpected antibodies. Okay? The cross-match. Please remember this. The cross-match, previously, many years ago, it was used to detect unexpected antibodies. All right? But it's no longer that way. Next slide, please. Okay. The 3-day specimen. I don't know if this is being enforced in our facilities here. The rule of thumb is if you draw the blood, for example, today, anytime today before midnight, we call that the day 0 of that specimen. Tomorrow is day 1. The next day is day 2. And it will expire on day 3 at 11:59 p.m. Okay? Technically, it's not valid for 3 days. It could be longer than 3 days, but this is how we count. Day 0, 1, 2, and 3 at 11:59 p.m. Okay? There is no need to draw a specimen as long as the specimen, we can hear you, sir. You cannot hear me? Transcription. The patient is tested for ABORH forward and reverse. The antibody screen is part of the pre-transfusion testing. I know since I retired in 2011, I've been going around the islands in many, many places. Many of us still do not perform antibody screen. And that is very, very sad. And I'm still, to the last day of my life, I will push for antibody screening because it is part of the safe transfusion testing scheme. Next slide, please. Nakamute pa rin ako. Plus that, all right? No skipping. Always the three-part. Patients ABORH, the antibody screen in the middle, and the cross-match. No omitting the second part of antibody screen. Next. Next slide, please. Next slide. Next slide. Okay. The evolution of the cross-match. I know many years ago, when I was a student, I was an intern at UST as a medtech student. We were just watching the physician, the pathologist, perform the cross-match. The cross-match using the spot plate. I don't know if you young folks, students from here, still use the spot plate. We just watch. We never cross-match. And that's what our experience was during that time. The cross-match has been modified many, many times. In recent years, the cross-match have been abbreviated, okay? The common types of cross-match that are being done right now are just the immediate spin for antibody negative patients, okay? That's why you need to do antibody screening. If your antibody screening or antibody detection on the patient is negative and there is no history of antibody on file, you can abbreviate your cross-match into immediate spin. The antiglobulin cross-match is used for antibody-positive patients only. Now, I know many of our facilities use cross-match using the gel or the bead column agglutination technique. And in some big facilities, some big donor facilities, they use the solid phase method. And now I'm going to discuss to you an electronic cross-match or computed assisted cross-match. Next slide, please. All right, let's discuss the antibody screen extensively. If the patient do not have a history on file, oh, by the way, I'll talk about history on file. Blood banks must have a communication on each other, on all the blood banks. There must be a antibody file that is being shared by everybody, because most of our patients, they jump from one hospital to the other, or they may travel from the Visayas going to Mindanao or Mindanao to Luzon. Then they don't bring their history with them. That's why it is. Okay. That's why it's necessary that we share. If somebody call you for an antibody history, you must not be hesitant to share it with other facilities. Okay. If the patient do not have a history of antibody on file, and the current antibody screening is negative, all right? No history, antibody screen is negative, the cross-match can be abbreviated, and this is when to save the money. All right? We perform an immediate spin cross-match only to detect ABO incompatibility. There's no need to carry the cross-match to AHG phase or to the Coombs phase. You don't need to incubate, you do not need to wash, you do not need to perform gel. No. You can completely avoid the serological testing by using electronic cross-match. And this is what we're going to discuss later on. Okay, the next part. Next slide, please. Next slide, please. Naku. Hindi. Previous. Okay. Okay. If you perform antibody screen and you have a history of insignificant antibody on file, and now the screening is negative, you can still abbreviate the cross-match. You can perform immediate spin, and there's no need to carry the cross-match to AHG phase. You can completely avoid serological testing by electronic cross-match. Next. Next. Next slide. Okay. If you have a positive antibody screen, all right, and the antibody that is identified is clinically insignificant, okay, insignificant, you perform cross-match to AHG phase. You need to carry it through AHG, not only an immediate spin. You need to carry immediate, you need to do the three phases: immediate spin, 37 degrees, and AHG phase. You do not need to provide antigen negative to the corresponding antibody, and it's not really necessary. For example, you have an anti-P1 or anti-Lewis A, all right? We consider this as clinically insignificant, all right? All what you need to is you perform a cross-match to AHG phase. All right? Next slide, please. If you have a positive antibody screen, now, your antibody screen now, at this point, is positive and it's clinically significant, you need to perform an AHG phase or the gel technique. You need to provide antigen negative blood, and you cannot use the electronic cross-matching. Next, please. Next, please. Next slide. All right. This is just a summary. Next. Okay, this is just a summary of what I have discussed earlier. All right. When the immediate spin, when the gel technique, and when the electronic cross-match is applicable. Go ahead. Next, please. Next slide. Okay. What are the limitations of the cross-match procedure? Though the cross-match procedure was originally intended for the detection of unexpected antibodies, it has its limitations. Ano ang limitation? It will not detect clinically significant antibody due to the dosage effect. Okay? Many times, we have antibodies that exhibit dosage. Okay? If they are in the single dose effect or the heterozygote, they may appear negative. Therefore, we have a false negative or false compatible unit that we cross-match. And the cross-match will not detect incompatibility from patients with historical records of previous antibodies. Next. Okay, let's discuss electronic cross-match. Electronic cross-matching was first introduced in the USA around 1992 by Michigan Medical Center. Okay. All right, okay. At the University of Chicago Hospital, where I used to work for 8 years, they beat us, okay, for few months, probably 1 year. I just not clearly remember anymore. But we implemented also the electronic cross-match. And I'm telling you right now, the best thing that ever happened in my 37 years of clinical practice in blood banking is the electronic cross-match. And I'd like to share that with you now. Next slide, please. Okay. What is electronic cross-match or computer cross-match? This is a type of major cross-match done without the need or contact between the donor red cell and the patient's serum. Many times we do the gel or the tube. We add the serum and the red cell together. All right? This time, no more. Okay? And in our facility, in my experience, we call it a paperless transfusion service. What does the blood bank do? Blood bank computer system do? It will just compare the ABO, RH type of the donor and the patient. Okay? We think that it's that simple enough, right? If you go to go a checkout in the dyan sa mag-grocery ka, if you go for a grocery, what do? You get a canned good, they will barcode it, and then it will give you the price. Almost the same, just doing the cross-match, computer cross-match. You have your results in the computer, you have your donor bag, you barcode it, and then the computer will just print everything out as compatible, if it's compatible, all right? Safety is ensured by computer controls in the transfusion service. Next slide, please. Okay. The purpose of the electronic cross-match is what? To respond faster to requests for blood to cut wastage by reducing the amount of allocated and stock blood in the system, and to reduce laboratory workload. Okay, next slide, please. Now, who are eligible for electronic cross-match? These are the patients with valid cross-match sample in the laboratory. Remember, I say we need to perform ABO-RH antibody screen, right? And it should be within a 3-day period, all right? Who else is eligible for electronic cross-match? Patients with no clinically significant antibodies. Therefore, if you do not perform an antibody screen, you will not be able to know if the patient has clinically significant antibodies. All right? You will not be eligible to perform or to use electronic cross-matching. Next slide, please. Okay, these are the people who are not eligible for electronic cross-match. The patients who do not have a current sample in the laboratory. Okay? Patients with clinically significant antibodies, patients who are bone marrow patients and stem cell transplant patients. Many times, most of these, they show mixture of blood due to the transplantation, and neonates or babies less than 4 months, because we routinely issue them O-negative pediatric units, and we do not actually even cross-match them only during the first time, using the mother's blood and the baby's blood if possible. Next slide, please. Okay, ay namatay naman. All right. Okay. Worldwide use of electronic cross-match. Computer cross-matching is used by many institutions many years back. It has been there for many years. I just want to know, hopefully, this would be used by us here in the Philippines, because it is one of the best things that could ever happen to us. Next slide, please. Now, how do we implement electronic cross-match? Okay, very strict. There are current guidelines that must be enforced. There are regulatory requirements. In the U.S., in my experience, the FDA and AABB enforce the strict regulatory requirements when it comes to using the electronic cross-matches. Next slide, please. Okay, let's go. What are the requirements now? You think that you may want to use the electronic cross-match. These are the things that you need. Number 1, computer software. I know in many conferences that I attended, not here in the Philippines, with PAMET. I have gone to all these companies, and they try to sell their computer softwares, and they do have software for electronic cross-matching. Okay? The number 2 requirement is you must have a dedicated medical technologist with IT experience. This person must be double in expertise, must be an IT experience, and must be a medical technologist. A medical technologist specifically working in a blood bank must be very knowledgeable in all the facets of blood banking, because he is the one in charge. In my experience, we have a lot of Filipinos that work and went into IT, and became IT experienced. They do not perform anymore bench work in many hospitals, but they are dedicated to maintain the electronic crossmats in their facility. And by golly, they got so much compensation, and they are so well appreciated for their knowledge. Okay? The number 3 requirement for the electronic crossmatch is, of course, you need to have an SOP. You need to write a standard operating procedure. Number 4, one of the most difficult requirements for an electronic crossmatch when we try to enforce is the validation. In my experience, in the early 1990s, even late 1989, something like that. I completely forgot the years already. That it took us at least a year or more to validate, because we have to do a lot of stuff to validate this electronic crossmatch and make it as safe as possible. The number 5 requirement is the full integration of the entire blood, not only the blood bank, but the lab information system to our computer software and computer blood bank system. It must be integrated. Okay. Number 6, would you believe the most difficult step for us when we implement the electronic crossmatch is the training of the staff? Why? We have some experienced blood bank workers in there for 25 years, 35 years, already ready to retire, 10 years, 15 years. They do not want, and during the time, they do not believe the safety of the electronic crossmatch. It took us many months in order for us to train our people. Yes, they are going to take the training, but no, they don't do what we train them to do because they are afraid. They are not ready to change. And I could share with you lengthily our experience in training our staff when we told them from now on, take all the lab books, do not write anymore. Do not write your result, go directly into the computer, into your screen. What do? They still write on the desk with their paper. When we notice that, we say, everybody that writes on their paper or on their notes and then transfer it into the system, into the computer, you will be disciplined. That is the only way that we can. Because we all know, even with my students, I know I have many students in the audience right now. What is the worst error that you can make to have a fatal transfusion reaction? I know all my students are yelling right now, clerical error. Clerical error. Tama ako sa final exam. Pasado ako, sabi nila. And now, after we train them, we find them to be competent. All right? There is a checklist. Next slide, please. Next slide. Marami pa tayo. Tutulog. Next slide. Okay, the integration of lab information system. I mentioned this already. All right, the LIS system must be integrated with the electronic crossmatch. Next slide, please. Next slide, please. Okay, what are the requirements? Okay, now we try to validate. We try to see the requirements of the safety of the electronic cross-match. The computer system contains logic to prevent assignment and release of ABO incompatible blood. Okay? What is a computer logic? Okay? Sabi ni Ma'am Joanne, wag daw masyadong technical, I cannot avoid this. Okay? Okay, I will answer all of that later. Okay? I will answer all your questions later, please. Okay. What are these logic? The computer logic is to create an artificial intelligence on the on our system. All right. What do? A computer is not as good as the person inputting what we need to do and what we need to see. All right. If a patient has no clinically significant antibodies in the recipient and serum plasma, there should be, it's part of the safety of the electronic cross-match. If the patient has a previous record of antibodies that are clinically significant, then you cannot use the electronic cross-match. That's why it's very important that we need to keep a record on file of our patients, especially those who has a history of clinically significant antibodies. All right, this is one thing. All right, there should be concordant result of at least 2 determinations of the recipient's ABO type on record on which one is the current sample. This is how we do it, all right? You have a patient right now, first time hospitalized, first time pa lang. Of course, there's no history of blood typing in the past kasi first time pa lang niya. You draw a specimen because it's a requirement for an electronic cross-match. You perform ABO-RH, okay? I am the med tech. I will do ABO and RH on it. Then there must be a second person who will do a blood typing on the same specimen, or if you're working alone, the recommendation is you do it now, stand up for a while, walk for a while, that's what they said. Walk for a while and then do it again. And then you have 2 determinations. Or if the patient had been in the hospital many times, there should be a history. So if the patient has a history, you can just do 1 typing on the current specimen. That is sufficient. There should be critical elements of the system that has been validated on site. Okay, what do we validate on site? We do truth table. What are truth tables? This is the breakdown of a logic function by listing all the possible values the function can attain. Ano ibig sabihin nito? When we validate, okay, the computer system, all what it does is just compare the patient and the donor. All right? Kung parehong blood type nila, okay, O positive, compatible, wala. Very easy. That's it. No antibody screen before, no. Everything is negative. How about an O negative to give to O positive? That's different now, but still compatible, right? Now, those are the logic I'm talking about. Another one, very typical. You have an RH positive patient, okay? You do not have an AB positive donor. Now, all of these are all possible. A positive, B positive, O positive, O negative, A negative, B negative. These are all the truth table that we need to put in there. So the computer would say, okay, all of these are all acceptable. All of these are all okay, and they will be compatible. And it takes us many, many times to see all of those when we begin to enter them into the system, and the system would say, for example, you give a B positive to an A. Would it say compatible? Kung compatible, you crush. Okay? Hindi. It should say incompatible. Those are the safety measures. All right? I hope I mentioned this many, many times. Okay, I have about 15 more minutes. Okay, next slide, please. Let's go onto the other trends. What are the barriers in the electronic cross-match? Okay, the time for validation, it takes too long. You must meet requirements, the training, and the software. The software may be a little bit expensive, but eventually, it will come out cheaper for most facilities. Next. What are the benefits of the electronic cross-match? Despite those barriers, the use of electronic cross-match will likely increase to cut costs and reduce the turnaround time. It's so fast that, you know, at the University of Chicago hospitals, we maintain thousands of blood because we issue blood by the hundreds a day. I have 4 medical technologists just issuing blood, 4 of them at the desk, just doing barcoding because we issue hundreds of blood a day. Laboratories are facing staffing shortage due to lack of graduates, and just like us, we are already, most baby boomers, we are now retiring. And the implementation of electronic cross-match can help blood bank reduce costs and improve quality of service, just like what I mentioned. This is the best thing that ever happened in my career as a blood banker, is the electronic cross-match. Next slide. Okay, in summary, an electronic cross-match is nothing more than using a computer to assign a blood to a patient. The sole purpose of this is just to confirm the ABORH of the patient and the donor. It cannot prevent hemolytic transfusion reactions. It cannot prevent hemolytic transfusion reaction due to clerical errors. Okay? Hindi yan magagawa ng electronic cross-match kung yun ang inaasahan ninyo. Next slide, please. Let's go. Okay, what are now the trends? The trends, okay? These may not be new trends. These are maybe old trends already, but some of these may not be being used with us. But I know most of these are now being used, and these methods are now being employed by many of our facilities. Okay? The pre-transfusion test is used only to detect only clinically significant antibodies. Marami itong procedure na to. How to do it? You know, by eliminating the immediate spin cross-match, if you by using the gel technique. Okay? Testing the weak D for transfusion patients. Okay? I know this may not be applicable here in the Philippines because we have very rare RH negative patients. Okay? But if you have a donor that is honest to goodness, RH negative, if the immediate spin RH typing is negative, it is a must that you must carry it through the Coombs phase of testing, because as a weak D being transfused to a patient that is RH negative, it may mean an immune response. It may make an immune response to the patient receiving the unit. Illusions on newborns we do not perform elutions anymore on babies that are, or the cord bloods that are direct combs positive. If the mother is if the mother is O and the baby is A or B or other than O, we just assume that the HDN or the positive DAT of the baby or the cord blood is due to the ABO incompatibility between the mother and the baby. Okay, patients with historical clinically significant antibodies, we perform only abbreviated identification by using selected cells only to rule out additional antibodies. Okay, I know that we have experts in here in the Philippines. Ma'am Sally Chua is one of them that performs antibody identification. I don't know if this is being done in here right now, and if there is a history of clinically significant antibodies. I give you an example. If the patient has anti-Duffy A, anti-Kel, anti-Big E historically, now the patient comes to us, present us with this history, and then we have a positive antibody screen. When we identify, we do not need to run a full panel. All what we need to do is just select to rule out all the other clinically significant antibodies. All right? The other trend is the methods for antibody screen that tend to detect all antibodies is decreased in use. What does this mean? If we think the patient has cold antibodies, we try not to use polyspecific anti-human globulin because of the possibility of detecting cold antibodies. And the wide, number 6 is the wide use of immediate spin crossmatch. I have a few more minutes. Next slide, please. Okay, the decreased turnaround times. Right now, if we do not use the gel technique or the solid phase method, the recommendation right now is to shorten the incubation time by using the enhancement media that will decrease the incubation from 30 minutes or 45 minutes to just 10 to 15 minutes by using gel, by using LIS, or PEG. All right? Next slide, please. Okay. Transfusion services. These have been widely used now in the U.S. It started by a blood center in Philadelphia, and we were one of their customers. What do we do when we say wired, regionalized, or centralized? Just like here, I give you a big example, PBCC, Philippine Blood, PBC, Philippine Blood Center. If you are the main transfusion service, you are wired to satellite laboratories that do not have a capability of performing all the major work of a blood bank. You are wired together. You are all connected. What do? You perform at the PBC, you perform all the antibody screen, identification, and all that stuff, and then you transfer the blood to all your facilities, just like dialysis center, nursing home, or convalescent homes, or small hospitals, or even medium-sized hospitals that do not want to have a blood bank. You can do it there, right there. And what do? They are, since they are wired together with the main laboratory, they just do the electronic crossmatch. All right, next slide, please. blood substitute. This has been here many, many years. Okay, the needs to maintain constant supply of alternative blood, to overcome complex procedures. And what are these? These are blood substitutes, and many, I know that this may be very, very expensive, and right now, it's still the voluntary blood donation is still the one being encouraged, but I just include this one because who knows, some people may want to use them. Okay, next. Next. I have a few more. Next. Next. Next slide, please. Next slide, please. These are all the different red cell substitutes. I'm not going to discuss them anymore. I just got them from my resources. All right. Okay. There are also platelet substitutes. Okay. And these are freeze-dried lyophilized platelets, synthetic platelets, and these are made up of microspheres of human albumin coated with human fibrinogen. I don't know. If you ask me how much this costs, I don't know. If you ask me if these are available in the Philippines, I don't know. But I just put this together, and when I was researching, what are these that can be employed and who may want to use them. Next. What are the new technologies? One of the newest technologies right now is this number one, molecular testing on PCR, okay? I know this may be very expensive, but I don't know if this is, hopefully this will be feasible, because right now, as I go and see the different blood banks around the country, and I have visited a lot of them, we do not even have an anti-sera for all these different, just like Duffy, Kidd, MNS system, and all the different major blood groups. Now we need to go into the world is already on molecular techniques. All right, so I'm just mentioning here that molecular techniques, blood group genotyping, using for all these different blood groups, including HLAs, okay? Of course, there is a lot of us using the gel technology, column agglutination technology, and erythrocyte magnetized technology, all right? Next slide, please. Okay, just like the blood bank systems, we have all of them, okay? And there are computer systems that have been developed specifically to assist blood bank professionals in the management of patients, donor, and blood components. I know many of us, we have them here, okay? And for donor records and all that stuff, what is the best feature of a blood bank information system? The clerical errors are avoided. Next. Okay, core blood banking. I know that there are a few facilities here already using core blood banking here. Okay, what is core blood? It is contained within the umbilical cord in the placental circulation. Once we are born, they get part of the cord, and then the core blood banking, they preserve this for so many years that according to the expert, and I'm not the expert in here, that you can use these cells to fight whatever diseases in the future there may be, and these are being preserved in the deep freeze. Okay, next slide, please. In vivo cross-match. What is in vivo cross-match? In vivo cross-match is, okay, I'll share with you my experiences in here. As I go around the country, again, I keep mentioning this, because of my experience here, is that people begin to call me and as far as sometimes Cebu, Zamboanga, Davao, Ilocos, Cagayan, and all the parts of the country. And then they asked me, sir, I cross-match 2 units, they were incompatible. And then they cross-match another 2 units, all incompatible. What did you do? I cross-match all the units. That seems to be type-specific. They are all incompatible. And then I asked them, before I answer you and help you, is, do you do antibody screen? They said, no po, we do not do antibody screen. I think that is the major problem. The major problem is you do not know that you may have an antibody there. Right now, my help with you is I am doing a wild guess. My wild guess is you have an antibody which we call warm autoantibody that in many or in 100% you would never find compatible blood. And what do? And this is what we do. We do in vivo cross-match. When we do in vivo cross-match, we transfuse the patient with least incompatible blood. Least incompatible blood means that if you cross-match 10 units and out of the 10 units you have an incompatible, which is the weakest, probably weak plus or 1 plus, that is the only way, that is the only unit that you can transfuse. The one thing though is how to convince our physicians. All what you need to do is ask them to sign a waiver. We call it waiver. In my experience, we call it emergency release. That the doctor would have to sign with least incompatible blood. And many times the doctor would be shocked and then would say, I would not. And then what do I tell the medtech? Doctor, even though you killed me, you hung me right now, I cannot find compatible blood for you. Now, your back is at the wall. You need to transfuse the patient. All right? And we do an in vivo cross-match. If you do transfuse the least incompatible blood, you must observe the patient. You must observe the patient, and after several ml of blood, you draw, wait for a while for that blood to circulate, and then draw a specimen and try to do a bilirubin. If the bilirubin, after transfusion of at least 50 ml of blood, is less than 0.5 milligram per 100 ml, mind you, every facility can set their own guidelines. It could be lesser than this, it could be more than this. It's up to the doctor, to the medical director to enforce this. Okay? He would say, only, okay, I want 0.6 milligram. Okay? It's up to your facility. I'm not dictating this, but in our experience, this is it. All right? Next slide, please. I think this is the last slide. Delivery of blood using drones. Okay? Drones are now being used in many parts of the world, mainly in Africa, in South African nations. Okay? Because of the proximity of the patients. All right? Drones are enabling to improve healthcare delivery by providing faster response times, reduce transportation costs, improve medical products, services to remote and unserved environments. Now, you ask me, paano ho ito ginagamit? Hindi ko alam. I have to be very honest. I was even it has not been my experience using drones. But during my research, they are now using drones to deliver blood to remote areas of the country. I think this is it for it right now. Thank you for having me. These are my references. And any questions, please? And I'd like to invite you guys tomorrow. I have 2 topics tomorrow. All right, thank you. Any questions? Ito. It says in here, one question. Sir, how many hours after blood transfusion are we going to extract blood from the patient for in vivo cross-match? Okay, as I've said, it's up to the facility to enforce how many hours or how many minutes. In my opinion, it should be at least half hour. Stop the transfusion, draw the blood, do a bilirubin. But it's up to the facility to say, okay, we need to wait 45 minutes. Okay, we need to wait 1 hour. It's up to you. I am not going to dictate that. Okay. Regarding gel cross-matching, sometimes we get auto-control positive. Is there any implication if we transfuse and release as compatible? Do we still need to inform the patient's physician that the autocontrol is positive? Definitely. Definitely. Anything that is irregular in your process must be communicated to the ordering physician and to your blood bank medical director. We as medical technologists, we need to protect ourselves. All right? Now, all what you need to is to find out why is your autocontrol positive. Okay? It's up to you to investigate. You cannot transfuse the patient without setting up everything in the right place. All right? You may say, I cross-match a unit. It's compatible. So what? It's compatible, but you still did not know the reason why you have an autocontrol positive. What's the reason for it? Other questions, please?
Yes, hello, sir.
Regarding antibody testing, is it dependent on the history of illness of the donor? If the patient had a prior history of COVID-19 in the rapid test or someone. Salmonella, dengue, do we screen on these diseases? No, no. We do not screen right now. As far as I know, that we have only the 5 screening tests. All my students know this. The disease testing, the TTI, transfusion, transmitted infection that we test are 5, right? All the medtech students know about this. Number 1, syphilis, hepatitis B, hepatitis C, what else? HIV and HCV, right? So we do not test for salmonella or dengue or COVID at this time. I don't know if they really are, okay? I think Dr. C addressed this earlier about the COVID-19 lengthily, all right?
All right po, Sir Ricky. Thank you very much for that.
Sir, how many hours after do we? Okay. in vivo cross-match ito. Okay. Thank you so much. Thank you so much.
Sir Ricky, can you hear me? Hello po. All right, for our next question, sir. Hello, sir. For our next question regarding the antibody testing, is it dependent on the history of illness of the donor, like if the patient had a prior history of COVID-19?
We don't perform antibody screen. You do not perform antibody screen, but you use gel method. Many reasons that they give is it is very expensive to perform antibody screen, but you use the gel. It's very expensive. I don't see the logic in there. Okay? Before you use the gel, do antibody screen.
All right. Thank you very much, Sir Ricky. For our next question, do we have a record or data of how many hospital laboratories are performing electronic cross-matching? Hello, Sir Ricky. Are you still on the line?
Ang daming gumagamit ng gel technique but they do not perform antibody screen. I think that's it. Wala nang question. Is there any other questions? Thank you so much, guys. Lakas ng ulan sa labas. Thank you.
All right. Okay, thank you very much, Sir Ricky, for...
Ay, natulog na sila.
All right. Thank you very much for that very interesting trends of blood banking, Sir Ricky. So for us to present your for your certificates, allow me to read again our simple certificate of appreciation. So as we read, Republic of the Philippines, Department of Health, Public Health Services Team, National Voluntary Blood Services Program, awards this certificate of appreciation to Mr. Felicissimo D. Martinez Jr. in grateful appreciation for his invaluable dedication and commitment for sharing his expertise as one of the webinar speakers of National Blood Donors Month 2020, Duguyanihan, Isang Pamilya, Isang Lahi, Isang Bansa, on 28 July 2020, facilitated by the National Blood Services Program Department of Health in celebration of the National Blood Donors Month from 28 to 30 July 2020. So issued on 28th of July 2020 in Quezon City, Philippines, signed by our dear Assistant Secretary of Health, Nestor F. Santiago Jr. Once again, thank you very much for tuning in, and thank you very much for all our dear speakers, for our participants who stayed kahit late lunch na po. Maraming salamat po. And of course, tomorrow we all will have another webinar series and hope to join with you again, ladies and gentlemen. So happy lunch to us and happy Duguyanihan 2020.